Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Hey everybody, how's it going? My name's Prof. Peter Malliaras. I'm an academic and researcher at Monash University. Interested in tendons. Surprisingly, to myself, more than anything, I've been sort of in and around research for tendinopathy now for over 20 years. And this probably is important for this Talking Tendons episode, because I'm going to be talking about palpation. And during my PhD, or maybe it was just before, one of the papers that was published by Jill Cook, Karim Khan, and a few others, including Craig Purdom, was a paper looking at the reproducibility and clinical utility of tendon palpation to detect patellar tendinopathy, published in British Journal of Sports Medicine in 2001. So it's actually going to be about palpation and the utility of palpation, this podcast, but it's going to lead on to a systematic review that one of my PhD students just completed. His name is Bara Al-Sulaimani, and I'll get onto that. But I guess when you're thinking about palpation, there's two things to consider. One, is it useful for diagnosis? And this is what this original Jill Cook paper from 2001, which takes me back to sort of the start of my PhD, around the time when I was, first read the paper and thought it was a really interesting paper. And it sort of has been quite influential for good reason as well. It was probably the first paper to look at the utility of palpation for diagnosis, and before that people sort of accepted that you diagnose by palpating if it's tender, and I think some people took that to the extreme where they would say, okay, if you've got a tendon on palpation, that's it, that's all you need, you've got your diagnosis, job done. And we know now that that is certainly not the case, but that was similar to, I guess, the thinking back in those days that if you've got pathology on a tendon, job done, you've got the diagnosis as well. We know, obviously, we've got a much more nuanced, interpretation of these test findings these days. So this paper in 2001, the title is Reproducibility and Clinical Utility of Tendon Palpation to Detect Patellar Tendinopathy in Young Basketball Players. So I will leave a link to this one as well. It's definitely worth reading. So in effect, what they have looked at here is a cohort of junior jumping athletes, and these guys and girls are at risk of patellar tendinopathy, and they looked at, there was a natural group that did have it, i.e. painful patellar tendinopathy, a natural group that didn't have it, and they did palpation on each of them. They rated the palpation as mild, moderate or severe tenderness or no tenderness. So they were all active jumping athletes, some with pain, some without pain, and then they just looked. So they diagnosed patellar tendinopathy based on clinical diagnosis, and then they looked to see whether palpation was going to be sort of predictive, I guess, sensitivity, specificity, positive and negative predictive values for people that have pain. They also looked at the reliability of palpation, and I'm pretty sure they tried to predict also ultrasound findings. I'm not going to go into that with this. I'll focus more on the pain prediction because I think that's more clinically relevant for people like us who are probably seeing patients in clinic and then wanting to use palpation in your diagnosis, seeing what it adds. So the main findings were that it was reliable. So using palpation, the way they did it was reliable, and this is patella tendon. So that was the first major finding. The other major finding was that if you look at the sensitivity and specificity of tendon palpation for painful patella tendinopathy, it wasn't very good. The sensitivity was better, which was 68%, but the specificity was very low, which is 9%. And that effectively means that you've got a whole stack of people that don't have patella tendinopathy, but do have palpation tenderness, and that's why the specificity is very low. And that makes sense. We've all had the experience of palpating people who don't have pain, yet they're really painful when you palpate them. So, clearly not everyone that is going to have palpation tenderness has a diagnosis of patella tendinopathy, and we know, and I guess the real contribution of this study was that yes, this is now been shown in a large empirical study. We now know that we shouldn't just be relying solely on palpation. It doesn't mean it's not useful at all. Probably is useful, but in combination with all the other assessments, one of the things that I think people accept these days is that given the sensitivity is quite high, if you've got the absence of palpation tenderness, then you can be more sure to rule out a diagnosis of tendinopathy. And there's work being done around gluteal tendon more recently in regards to utility of palpation. So this was a real early contribution and a good study for that reason, but that's sort of where the clinical utility landed, in that it wasn't really that useful based on the findings of this patella tendon study. So that's interesting. Now, that takes me to another reason why we might do palpation. So aside from just looking at palpation as a diagnostic test, people also can use it for, and have used it multiple times in the literature, as an outcome. So some people might be surprised with that, but people have used palpation as an outcome. So how much palpation tenderness do you have? So that was one of the things that my student Bara Al-Sulaimani was interested in. So he's the first author of this review, as well as a bunch of other people. And the title is Evidence for Improvement in Local but Not Diffuse Pressure Pain Thresholds Following Physical Therapist Interventions for Tendinopathy. Okay, so effectively what Bara did in this work was look at prospective studies looking at exercise and other interventions for tendinopathies, general tendinopathies, a whole bunch of them, not just patella tendon or Achilles, and looked at pressure pain threshold changes over the course, as well as pain changes over the course of those interventions. And the main reason was to see how they change together. So is it is it true that if you have improvement in pain, also you have improvement at the same time of your pressure pain thresholds, which is just another way of measuring palpation tenderness, I guess, just a more specific way of doing it, or maybe not specific, but I guess you could say more reliable, I want to say, than palpation by just using your thumbs and digging your thumbs in. The reason I say that is because you can at least measure how much pressure you're applying. So he was interested to see, do these changes co-occur? Do they change together? But also, as we know, the pain mechanisms for tendinopathy are not really known. We know that there's probably peripheral sensitization. There might even be central sensitization in some people. So we were interested in because pressure pain thresholds can be proxy measures for sensitization. If they're done locally on the painful tendon, they're proxy for peripheral sensitization. If they're done away from the painful site, they may be a proxy for central sensitization. So we're interested in seeing whether these proxy measures changed as well. So as I said, he sort of reviewed the literature around all tendinopathies, and I'm going to cut to the chase here and keep it really clinical for everybody. He basically found 18 RCTs. 9 were of low risk of bias, and the remainder were moderate or high risk of bias. And most of them were looking at local PPT changes. So I think out of the 18 studies, majority were looking at just local PPT changes, so pressure, pain at the actual painful tendon, and whether that changed over time. And what he found is that it did change, but it was more likely to change at longer time points. So if you're getting out to more sort of, a few weeks and beyond, the tenderness was more likely to change. Bear in mind that there wasn't many studies that looked at outcomes at very longer time points, like a few months. So we didn't have much data, so we're less certain of those time points. That's something to bear in mind. And the other thing that we found is that not many people look at diffuse PPT change over time. There's only a handful of studies, so again, we're not really certain at all about those changes, so I'm not going to talk about those changes very much. I reckon the most interesting part of Barra's systematic review is how pain changed in combination with PPT. And what we found here is that you can have pain changes really quickly that don't necessarily are not necessarily accompanied by changes in pressure pain. So pressure pain seems to lag behind, and I guess there's a real good key message for patients in that. If you're in a patient interaction clinically, and patients often ask us, look, the tender, when I touch it, it's really, really tender. Is that a problem? Even sometimes they would say that after they have improved in terms of other pain measures like load or movement evoked pain. So I really commonly have people coming in and they're pretty good. Things have improved. They're back to activities, walking and running, but they might have a hamstring problem and say, look, when I sit on it, I putting pressure on it, it's still painful. Or when I touch it, it's still painful. And it's very, very, very common and normal, and you can reassure them that it's not a problem. Having said that, hamstring tenderness when you're sitting on it can be a real lingering problem for some people. But our data tends to suggest that even though the changes in pressure pain are slower, it does improve over time. Okay, so that's a reassuring message for patients. And that's with a whole stack of interventions. We weren't able to say definitively improves with this or that intervention because we just pulled them all together for the purposes of this review. So that is pretty much all I wanted to mention for this one. I think I've covered most of the key clinical points. So reassure your patients. The other thing that it sort of also suggests is that palpation is a slow, palpation tenderness or pressure pain is slow to change, so probably not the best outcome to be using. And when we did our international tendinopathy consensus of core outcome domains, we didn't include as one of them palpation tenderness. Great, so look, I'll leave it there. Hopefully that was helpful with some clinical tips, and I'll see you next time. Thanks very much.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.